welcome everybody to the Touch Yourself show. Uh, and I'm your host, Toyin Adeshola. And with me, I have Yomi Oyelami. Hi, Yomi.
Good evening. Good evening, ma. How's everything, ma? How's your day, ma?
Very good. Tried to be restful, but I didn't. I did not succeed. I think these
You
are
have
the
to
challenges
start
of
this.
being an adult. You think too much. With a child, it's easier to just have fun, play. That's all you do, and let the parents do all the worrying.
Exactly, exactly.
Okay, so today it's we are on to Touch a Cell show, a production of Sickle Cell Advocacy and Management Initiative, and we hold every first, second, and last Saturday
Okay.
of the month. So if you're watching from Facebook, please help our algorithms by liking it, and if you're
Yes.
watching on face sorry, if you're watching on YouTube, help our algorithm by liking it, and our Facebook, make your comments and share and listen, because we're going to learn a lot about the challenges of moving from childhood to adult care. And we have lovely guests on board. And so I'm going to be introducing them as we have them all ready and waiting to discuss with us on this particular topic. And the first person I'll bring on is Dr. Abimbola Mabogunje. She is a consultant pediatrician and also the medical director of Mercy Street Children's Hospital. And it's a great responsibility to be a medical director of Mercy Street, especially a government hospital with children.
Wow.
I will
In
be
fact,
going into the cases of dealing with parents and their fears.
Yes, so
And
thank you, Toyin. Yeah.
the history
welcome,
of that hospital
Abimbola.
itself is something to worry about. It's
Yes,
something
exactly. Exactly. Then
Yeah.
next we have uh, sickle cell warrior, Omo. Welcome,
Yay!
hi Omo. Welcome on board. Uh,
Good
you know,
evening. Good evening, everyone. Good evening,
Ah,
Ma. Thank you, Ma.
good evening. Nice to have you on board. And then our final guests, very special
Good
guest,
evening.
like
Nice to have you
Dr.
too.
Babu. She's very busy. We have Dr. Olufunto Kalejaiye.
Good evening,
She
Mama.
is a
finally.
hematologist at Lagos University Teaching Hospital, a very busy woman and very in-demand woman with adult. I'm sure you don't tire for her side.
Not at all. It's always a pleasure to hear from you. Good evening. It's a
Good
pleasure
evening,
to be
ma.
here.
Great to
Good
have you
evening,
here.
Ma.
Good
I'm glad
evening.
we're going to discuss this thing, because I remember growing up, um
Thank you for
I
having
always,
us.
yeah, you're welcome. I remember when I was growing up, there was never a disparity between adults and childcare when it comes to sickle cell. It was always just one doctor. And I think as I grew older, I think based on the parents, parents are the ones always taking care of you. They're always bearing the brunt of everything. But as I grew older, I realized that there was a disparity because I didn't know much about my illness as I should have as I was growing older. Because I maybe because in those days parents felt don't tell much, let's look after her and all that. But I still see it as a challenge in that people don't find it difficult trying to balance and move away from the pediatric care and then facing the adult care, especially when it comes to their mental and physical needs. So it's great to have this discussion today. And I'll kick off with the first question, and that goes to Dr. Maboguje. Being in charge of a child hospital. I know you come across. You've also volunteered for us in our clinic, touch extra care, and
Extra
I know you
care.
come across a lot of parents who, how will I call it, who have challenge in knowing how to manage their children. How do you suggest they do that in the first place. Because sometimes they just feel, oh, Shebi is just ordinary sickness, and as you and I know, some of them leave it till the wahala don't reach uh, major issues.
Yeah. Okay, thank you, Tony, and it's really great to be on air with all you lovely and wonderful people. So thank you for having me. Yes, I see a lot of children with sickle cell disease, and therefore I see a lot of parents, mothers especially, and some fathers that come with their children with sickle cell disease. I think the most important thing or the biggest challenge we have is for them initially to accept that the child is unwell and needs care. So there is usually some form of denial initially. Not everybody, but some of them will deny the fact that there is anything wrong with their child for the longest time. And usually they will come back only when there is a crisis. Sometimes when the child has a stroke, and then even after that, they might default for many years and then come back again. I think the most important thing initially is that first, second, third contact. So try to educate the parents as much as possible about the condition of their child and the things they will need. The other major challenge we have is finances. Having a child with sickle cell disease can be very expensive, and we know what the country is talking about nowadays. We know what we can see everywhere, and they sometimes just can't cope and can't manage the extra finances, the extra money for drugs, and extra money to look after the child if the child has a crisis. So those are some of the issues that we have with them. But I think the first thing is for them to accept that yes, there is this condition, and give them all the options and show them that there is hope. I mean, a child with sickle cell doesn't have to die. Nowadays, a lot are surviving much more into adolescence, adulthood, and even old age and things like that. So those are some of the few challenges we encounter with that age. Yes. I hope
Okay.
I've answered some of the questions.
Yes. Over to you, Yomi.
Great. So thank you very much, Dr. Mabogunje, for that question. So my question will be, now you've just laid a foundation on sickle cell, how parents have denial of sickle cell and everything. But Dr. Kalejaiye, I would like to
Yes.
pose this first question to you. Now, you are an hematologist. Can you help us lay the foundation? Can you give us the basics? How did we come about sickle cell in the first place? So that people can understand. A lot of people don't know about this. Can you just break this down in the most basic form for people to understand?
Okay, so I'm going to be as simple as possible because I know most of our audience may not be medical.
Yeah.
So, sickle cell disorder results from an acquisition or acquiring the abnormal S gene. Now, the normal genotype for most people will be genotype AA. But where there's a problem with the hemoglobin structure, there is formation of hemoglobin S. And this hemoglobin S is inherited, it's not acquired. It's passed from parent to child. So when there's an acquisition or an inheritance of a homozygous or hemoglobin SS, usually from each parent, passed from each parent to the child, that child comes out. We say the child has sickle cell anemia. Okay. We find that it's important for people, and we've been seeing it over and over again, to know what their genotypes are. Because when somebody with hemoglobin AS, who is a carrier, gets married to another person who's hemoglobin AS, who's also a carrier, every child they carry has a 25% chance of being homozygous for hemoglobin S, that's hemoglobin SS. So it's not 1 in 4 children, it's every child or every pregnancy has a 25% chance. So first things first, knowing your genotype is important such that informed decisions can be taken. It's not acquired. These children are not Ogbanjes. Nobody gave it to them. They simply inherited this gene from their parents. Okay? Yes.
Fantastic. Thank you very much for that answer, man. Thank you very much for that answer. So, Omo, I'm coming to you. You live with sickle cell, and I believe you agree with what Dr. Kalejaiye has established for us. Now, as a child, moving from childhood to now that you are an
Yes.
adult, can you tell us how has it been for you? What has your experience been like going to school with parents? How did doctors treat you when you were a child? And now that you're an adult, what's the treatment like now? Can you tell us?
Okay, good evening, house. Good evening, Dr. Kalejaiye. Good evening, everyone.
Good
Okay,
evening.
how it has been like a someone sweet story, something like that. Because I grew up in a single parent home. My dad left when I was when my dad left when I was young, so it has been like that. Um, for me, I would say being born with sickle cell anemia brought about discrimination, brought about. When I was younger, I was actually treated. Okay, so um, I used to be stronger physically. My crisis wasn't that much. It was okay, but the discrimination was bad. That's what I was saying.
But you attended hospital very well that time.
Hello?
Can you tell us you attended hospitals? Your parents took you to the hospital regularly. What was the experience in the
Yes,
hospital
yes, yes.
then? Yes, how they take care of you, and I want you to just do like a contrast of what it was then and what it is now.
Okay, mm, it was okay because when I was younger, the normal look way you take the child to the hospital, the doctor tell you what to do. Some of them shout, some of them don't. But it was okay, and it's still okay.
Okay, okay. But did you have
Okay, go ahead.
all right, Omon, did you have
You want me to-
did the doctors then as a child did they treat you specially when probably when you were in the hospital and adults came to the hospital and you were also in the hospital, but they said, this girl is a small girl, let's take care of this girl first. Did something like that happen? Did they give you preference?
I don't think I remember.
Exactly.
No,
I don't think
I
she
never felt ill. I wasn't felt ill that frequently.
Okay.
Okay, all
yeah.
right.
Yeah. Actually, I would even say
Yeah.
from my own point
So that was
of
one
view,
advantage.
yeah, yeah. It's. I think it also depends on the hospitals you go to. For public hospitals, it may be more challenging. Yes, definitely. For private hospitals, if I'm correct, is because they have specialized section for each person. It may be easier to say, okay, we'll take care of the adults, and all that. But I want to come to Dr. Kalejaiye. There's this thing or this idea that there's a shortage of adults hematologists. I mean, pediatricians can generally take care of children even with sickle cell. But when it comes to adult care with people with sickle cell, I noticed that before you find hematologists within that space, it takes a lot. Because I keep telling people that hematology is not only for sickle cell. I think warriors believe that hematology is only deal with sickle cell. So
So
they must have them by fire by force.
no worry, we like to monopolize now. We like to monopolize our doctors.
Okay,
So
let me see if I can.
how can we improve that gap in terms of relationships with older people with sickle cell?
How do we bridge the gap? Okay, hmm. I think I'd want to explain what hematology is first. It's not just sickle cell, it's blood and
Hmm.
all blood disorders. So there's hemoglobinopathies, there's cancer, there's HIV, name it. So it's broad, it's really, really broad. And it takes a certain level of interest to want to be able to go into hematology. Now, I am actually a physician. I mean, I did internal medicine first, and then I went into hematology. So that makes me pretty holistic. But
Hmm.
not many people have the flair for blood and blood disorders because you have so many subspecialties in medicine. So hmm, I think first I think it's what we try to do now is we try to raise awareness about hematology and get our residents even more interested in specializing. It's about the
Hmm.
only way we can increase the number of hematologists that we have on ground. People are afraid of the morbidity, they're afraid of the mortality, especially with the oncology section, the cancer patients.
Yeah.
Like, no, no, we don't mind sickle cell, but we're not going to do cancers. And it's difficult separating one from the other. You have to manage them both. Now, when it comes to warriors
Hmm.
and adult care, we do have our challenges because some people coming from pediatrics believe, well, my child has done well thus far. And actually said that if my child can live above 15 years, older than 15 years, she shouldn't have any complaints anymore. Why must I bring my child to the adult section? After all, my child has survived childhood. On the other hand, we do have some other parents that are quite angry with the children for reasons best known to them. You know, I've been taking care of you all my life. Are you telling me this is going to continue till thy kingdom come? So we have those challenges to deal with. So again, we start by recounseling.
Mhm.
More often than not, many of our warriors have accepted what the problem really is. Some parents accept, and like I said, okay, I'm willing to continue. Some accept and they're quite cross. So we have to re-counsel, we have to involve the clinical psychologist as well. Okay. And then when we now present them with the barrage of investigations they have to do, that will sort out all, that would investigate all the systems. You look at the eyes, you look at the heart, you look at the kidneys, they're like, you mean I'm going to do all these investigations again? And don't forget, our patients are, they fund themselves. The treatment is really from their pockets. So that's
Hmm.
another added challenge that we have. And then maybe they need to buy drugs. That's another problem in itself. So we're not nearly there. It's really work in progress. And I believe there's still more room for improvement. But again, advocacy, advocacy, advocacy. And thank you, Sammy, for doing such a wonderful job thus far.
Thank
I
you
don't know
so
if I've
much.
answered
Thank
your
you.
question satisfactorily.
Yes, very well. And which brings me to because Dr. Mabogije was saying something about parents not understanding the challenges of their children and educating them as well. And I wanted to come to this. Would it be easier if a child starts educating sorry, if a parent starts educating the child at an early age what their disorder is about, what they should do, what they should not do, so that by the time they grow older, they are able to manage their health better. Because that is another gap I see. And if that is so, how can they do it? How can the parents start educating?
Okay, thank you very much for that question, Tony. I'm assuming you're asking me, Abi. Yes.
Yeah.
Um,
Yes, yes.
yes. I think nowadays we actually get the children involved in their care. So as soon as they can understand, we start talking to them directly. So you come for a clinic appointment with your child. We're asking the child how the child is from the child. The initial conversation is with the child, and then go to the parents, and then talk to both of them together and start introducing the condition to the child, what they need to do, how they need to look after themselves in small bits, so that each time they are being more aware of the condition. We allow them to ask questions. And we have something called support groups as well that they can join in, so that they are taking responsibility for their illness. They get to know as early as possible. We do it for most of our other conditions as well, like HIV, epilepsy, and things like that, so that they are aware of their condition, and they get to ask questions and they own it. They are the ones saying, oh, I haven't taken my medicine, or I didn't take enough water, or whatever it is that they need to do. So that's where it's tending towards. I know in your introduction, it was like in those days, children did not know what was going on. You understand? But nowadays, we want them to be aware. We ask them questions when they come to the hospital. We tell them what they need to do, and then also get their parents to support them in what they need to do. Yeah. But with regards going to the adult care, I think the transition is where the problem is mainly. You need to actually prepare a child from being a child to getting to be an adult, you know. And I know that a lot of people want to stay in pediatrics. They just want to keep going back to their pediatrician forever. But the condition changes as they get older, and the challenges are a bit different. So they need to actually transition. And maybe they think that there are not enough adults that understand them and things like that. And as pediatricians, we play with them, we talk to them, we do all sorts of things with them, and they want that to continue forever. But that is not it. So, yeah. So I think going forward, what needs to happen is that there needs to be a proper transition plan, a transition policy between the pediatricians and the adults. I mean, I work in a mono-specialist hospital, which means that when they go, they actually go. There is no, oh, I'm going to the pediatric department to see somebody and say hello. I can't go and physically hand them over to the adults, you know. So I have to actually do a referral to the adults. And they might never go there because there is no friendly face that they've known and seen, you know. So those are the issues that need to be talked about and dealt with. Thank you.
Yeah. Thank you very much. Before I hand over to Yomi, I'll ask Omo a question. Now, how was it for you? Were you educated on your disorder at an early age? Did your mother educate you about, or you sort of found your way around the matter? Omo, are you there? Your network is slow.
The network is
Can you hear us?
Amon, did you hear the question?
Yes, sir. Yes, my mother educated me. She read a lot about sickle cell. Now, she knew more things that the doctor would tell us or told us much later.
Okay.
Okay, that's good. That's good. At least that's somebody that has been able to educate you, because some parents don't bother. They keep everything to themselves, as it were. And it's good that you are able to be educated on that. So over to you, Yomi.
So, Dr. Kalejaiye, our warriors, they usually have these complaints about, I like this doctor, I don't like this doctor. Then, so if you don't give them that doctor, they don't believe it. Another aspect that we also have issues with is that they tell me that a doctor prescribed this drug for me to use. Then I meet another doctor and he says, never, don't take it. Why that disparity in prescription or understanding from doctors to doctors? I don't know. Can you help us clear that aspect?
Okay, I'll try to do my best. I mean, With the issue of doctor preference, I know I've been through a lot of that. I took over from Professor Kende, who was my boss, and
Okay.
patients come and each them they're like, oh no, we want to see Dr. Kalejaiye. And I'm like, we can't. I have to see all the new patients and I have to see the old patients as well. So we really can't cope. But we always tell them that, something, the other doctors are qualified, and where they have problems, they can always come with your case note or they bring you to me so we can reassure. But when the clinics are pretty heavy, it's difficult to extend that kind of service where a particular doctor gets to see a particular patient all the time. Now, when it comes to prescriptions, I think the question first is, well, I've seen people come from different centers with all manner of prescriptions. A lady came to me last week at the clinic. She's taking ibuprofen, and for no reason whatsoever. It was prescribed to her by her doctor. She's been taking it for as long as I can remember, and I felt, who gave you this prescription? She said, my doctor. For what? Oh, I don't know. But these are drugs that can potentially damage the kidneys over
Wow.
a long time. So it's possible that this person that be the suspicion probably thinks, oh, this person has sickle cell anemia, probably would have pain. Let me prevent the pain as possible, as much as possible, without considering the side effects that these drugs may actually have. So some do not really have a basic understanding of sickle cell anemia. Okay, and some really clearly don't have an idea of what to do for these patients. So we have that disparity sometimes from doctor to doctor. But we find that when we are trained in the same center, we're trained in the same subspecialty, we tend to prescribe the same set of medications.
And I think we also have that challenge too with parents. So this is where I want Dr. Mabu pause. Parents, they hear from their other parents. It happens a
Okay.
lot. They just tell me, yeah, something is also using this drug for our child. And because we meet in the same center, it must work. Since it's working for our child, it must also be working for my own child too. Can you help us address this aspect, Dr. Mabogunje?
Yeah, so that happens a lot. They get prescriptions from themselves or and things like that. But really, what's a lot is back to us as healthcare professionals to explain each drug to them and why they're using it, and also the side effects, and explain to them that you're giving this because of ABC. And it's not that everybody needs it, but your child needs it for this purpose, for this period of time, and things like that. So we need to go back and continue educating them. And I must say, some patients also misunderstand, or they just want to hear what they want to hear. And then they also go back and say, oh, it's worked for Yalagbaja, so it must work for me and my child. So we just need to keep educating and educating and educating and educating. We can't stop talking.
Okay.
So I'll fall back on parents too, because I know that definitely when they come, most of the parents are what will I call, they are panicking and all that, and they come to your clinic. Uh, and like I've called you a couple of times on some issues, they are already yelling, this
Yeah.
person is not answering and all that. Can you sort of educate, to like call it basic etiquettes for parents, when I know that yes, I can understand your pain, I can understand, but these are certain things that happen. These are the processes that happen when you come to a hospital, so that they don't panic and feel that they are being neglected.
Okay. So, I mean, basically, people need to be patient. It is not likely that a doctor will be sitting down, having a cup of coffee and chatting when your child is unwell or in pain. You understand? The nurses too will get up and do something. So if a child comes in as an emergency, all hands are usually on deck to make sure that that child is sorted out as much as possible. And once the child is admitted, there's a plan to follow. And obviously, if there's a problem in between, just get the attention of whoever is available, the doctor or the nurse, and it is usually sorted out. Now, because in most of our general hospitals and places like that, there's usually a shortage of healthcare personnel. In an emergency room, there might not be enough doctors or nurses. And there are other children that are unwell. So once again, it is patience. Kindly keep raising your hand and saying, please, I need help and all that and all that. I mean, I don't know what the best solution is. I think the best thing is for us to have enough bodies on ground to be able to answer everybody's needs. But the other thing also on our part is to educate the parents as much as possible so that one, they don't panic too much. We're able to reassure them with each contact that we have with them. We can also educate them on the things to look out for and what they need to call us for, so that they're not calling us for every single thing that is going on with the child. So that is one way to do it. But I think more bodies on ground, more nurses, more doctors available. And like Dr. Kalejaiye said, you can't get it all, not especially in the government setting, and not everybody wants to specialize in hematology. So those are the issues we have. And even when you train them a bit, they disappear to greener pastures.
Oh, yes.
Yeah.
Yeah, so I
And
keep
The
people
teasing
waste
japa.
now.
everybody that we're training for exports. So people
Oh,
come in
yes.
within a year or two, they're already asking for reference to go to the UK or Australia or anywhere. They're going
Yeah.
everywhere. So
Mm.
Yeah.
those are the
Yeah.
issues we have. Both doctors, nurses, physiotherapists, everybody, they're all
Mm.
going. Yeah,
Wow.
Wow.
Yeah.
Wow.
yeah.
Yeah.
Oh, okay. Dr. Kalejaiye, I wanted to ask,
Yes.
we talk a lot about the physical aspect of a sickle cell warrior, but one of the challenges, especially transition, is their psychological and emotional aspect. How can we as medical doctors holistically accommodate this? Because even in our clinic, you find that some of the warriors who see doctors may not necessarily have a physical issue, but they just want somebody to hear them out, somebody to
Mm.
listen to them. So I know a lot of times doctors are stressed because, especially in public hospital, there are so many they need to
Wow.
see. But how can we accommodate these issues? Because I see that affecting their health a lot, even sometimes more than maybe the physical stress or what they didn't take or did or took than any other thing. So how can we manage that situation?
Well, I do agree with you that the psychosocial or the psychological issues with sickle cell anemia cannot be downplayed at all. And you are right, many of our warriors actually have more psychosocial problems than physical problems.
Yeah.
Now, I know in the clinic setting, it's not very easy, especially when you have a large patient crowd,
Mm.
to
Mm.
sit and counsel every single patient. So what we have done in our own clinic is well, we do, thankfully we do have a clinical psychologist who
Okay.
Mhm.
we've recently had to refer quite a number of patients to. I
Mm.
remember my last clinic day, there was an angry mother and a very upset child. And by the time I spent about 30 minutes talking to them, other patients were yelling outside the door. And I realized I really couldn't continue with this anymore. So the appropriate referrals you have to know when to write those referrals,
Mm.
and to send them to appropriate personnel or qualified personnel that can help deal with these problems long term. Because they're actually long term issues. They're not just stop and start issues. They need to go for sessions of counseling, they go for reschedulings and scheduled visits and all, just to help them cope with their problems for as long as those services are required. So we've had to
Mm.
do a lot of that lately. Some will get away with maybe 10 minutes counseling session. So what's going on? Will talk to me about it, and they feel better when they leave. But more often than not, you do have to send them to clinical psychologists, which we've had to do a lot lately in my center. I don't know if this
Yeah.
And
answers
then
your
and there are
question.
not
Yes.
yeah. And there are
And they're
not
not
enough
many.
clinical psychologists
They're not enough
available.
at
They're not.
all.
Yeah.
At
And we
all.
need them
Mm.
Yeah. And we need
desperately.
them
So
desperately. You are right, Dr.
yeah,
Yeah.
Mabogunje.
yeah.
Yes.
Wow. Which even brings me, I was going to ask you, Bimbola, because there's always the
Mm-hmm.
case of, because a parent is fearful of the child, there's always the case of what I call overprotection,
Mm-hmm.
uh, not giving that child a life, in quotes. because we told if you do this, you fall sick. If you do that, so how can you how will I call it, or encourage or help parents to understand that yes, these things happen, but the moment you overput, because I experienced that until I burst out of the roof, as I would call it.
Yeah. Yeah.
They called me someone, they called me a visit because I was trying to find myself as it were. But I know quite a number of parents share this. I even know of a story where the child was not allowed to go to school. The child even wanted to learn baking. They said they stopped it and told the child to be sitting at home, to the point that when the child was now seeing guests that come into the house, because the person doesn't go out, she became fearful of, I will
Hmm.
run upstairs,
Hmm.
because she has not had that interaction. So what would you say to parents on this? And maybe Dr. Kalejaiye will add something to it as well.
I think every parent's desire is to protect their children as much as possible. But like you rightly said, we can overprotect. And and that is the advantage of talking to them, educating them, and also forming support groups so that they see other parents, they see how they're treating their children, they are able to voice out their fears and their anxieties. And even within the parents group, they can be reassured. In those
Mhm.
support groups, we have a healthcare professional and then the parents talking to each other. And then we can usually talk about issues that are raised up. And if the mother also wants psychological counseling as well, then, or if the parents, if the doctor notices that this is a bit too much, they can also refer them for psychological counseling as well, so that the child will have the benefit of all the good things that they have, as well as some protection. It's everywhere in the world. Some parents
Mm.
just over pamper and over protect when they feel that, and that's what they feel they can do, forgetting that the child will grow up one day and will need to be able to stand on their own 2 feet. Yeah.
Dr.
Dr.
Kalejaiye, do you
Kalejaiye.
have something to add?
Please, you can call me Funto. My name is
Mm.
Funto. Okay.
Okay.
So, like Dr. Mabogunje has said, the role of the support groups cannot be overemphasized. Well,
Mm.
I run a Luth sickle cell support group. I took it over from Professor Kende, who'd run that for over 20 years. And you are right. You do see warriors come together, they discuss their problem. They need to know, one, you're not alone in this. We
Mm-hmm.
also tell
Mm-hmm.
our warriors as adults, you must know the levels, or more or less, you must know the levels of your exercise tolerability. The fact that one warrior can walk from here or from Luke to Ojoelegba does not mean you can do the same. So every warrior is an individual by themselves. So you have to understand yourself. You must know this is a bit too much for me. Maybe this I can do better here. And the youth support groups also helps them. Oh, you do this. Oh, maybe I can give this a shot as well. Oh, so this is actually possible. It also helps, even their psyche as well. You know, we do have parents who pamper their children into adulthood. I remember a young gentleman who couldn't even tie his shoelaces. His parents never
Wow.
allowed him do anything,
Wow.
nothing. And I remember my boss was horrified. And we had to send these ones also to the social work, to the psychologist to educate. He was 27, hadn't done a stroke of work in his life. We couldn't believe it. So there's always that problem of smothering. But when they come to these social groups and they see warriors like themselves doing stuff, they're going to school, they're excelling in their duties. They're like, okay, something, I can do this as well. So I think the role of those support groups really cannot be overemphasized. But at the same time, care must be individualized. You must
Mm.
know
Mm-hmm. Mm-hmm.
the
Mm-hmm.
levels or the limits of your own exercise tolerability. That's important.
Yeah. Thank you very
It
much.
must
Over
be
to you, Yomi, for
individualized.
the last questions
Mm.
before we do the final close.
Omon, you live with sickle cell. and you have two doctors with you right now.
Yes, ma'am. Yes,
If
sir.
you are, if there's something you would like to ask them,
Yes.
what would that be?
If a child, can a child of 3 years, sorry, can a child of 17 years take um hydroxyurea?
Okay.
Take
I guess
hydroxyurea. Yes,
yes.
a
Why not?
17-year-old can. In fact, we start hydroxyurea from as early as 2 or 3 years old. So a
Exactly.
17-year-old can take
Certainly.
hydroxyurea.
So what would
Yes.
necessitate that?
All right. Do you want me to take that, Dr. Mabogunje?
Yes.
Or would you take that?
Oh
Yes,
yes,
please.
yes. Please go on. Yes.
Okay. So we well, the Americans and the British have their own guidelines, and the British actually start hydroxyurea for all patients that have sickle cell anemia.
Yeah.
We haven't updated our guidelines up to that level. So right now we still work with our indications for use of hydroxyurea. If somebody has had a warrior has had a crisis 3 to 5 times a year requiring hospital admission, or you have to give injections, or you have to give drips, that patient qualifies for use of hydroxyurea. If a warrior has had a stroke before, that patient has to get hydroxyurea. Okay. If we give our patients that have priapism, where there's sustained erection of the penis and the absence of the sexual desire, we have to take hydroxyurea for that as well. And a lot of other indications where you have, a patient requires, regular multiple transfusions, that person will benefit from hydroxyurea as well. Okay, and so many other indications. So we kind of work with our own national guidelines that give indications for use of hydroxyurea, whereas the Americans and the British give hydroxyurea routinely to all
Everybody.
patients that have sickle cell anemia.
Yes.
That's where
Wow.
we're at. Yeah.
Wow. Wow.
Interesting. Now I'm learning that. I just because there was
Yes.
also much clarity in the disbursement of hydroxyurea that I was wondering why. Now I understand it's because of the guidelines. I'm
Yes.
hoping that we could maybe something we need to push, like everything. We need to look into how we can push that. And I think the same thing goes for penicillin because I noticed abroad. People give penicillin like a routine thing, but here you see some doctors saying no, yeah, you shouldn't be put on penicillin. Do you have something to say
Yeah.
on
So the
that?
guidelines. So the guidelines for penicillin at the moment is up till 5 years old, but
Okay.
we know that you can give it after that. So, but I think we still haven't updated those guidelines as well. Yeah.
Wow. Wow. So if anybody has any questions, post your questions. We have just about 2 minutes more before we round up. Uh, Almo, if you have any questions, ask now because you have, as I said, two powerful doctors at hand. But Alma, I wanted to ask you something. Did you have any, so I call it emotional or psychological challenges in trying to move from when you were a child to adulthood? Did you face pampering of such and all that stuff? Did you have any challenge in that process?
I would say I would say pampering, and I would say pampering. It was in between because mom do some certain things I wanted to do like
Unfortunately, can't hear you well.
Find it.
The network is poor.
Yeah.
Okay. Yeah, the
so
network is. We can't hear you well. Unfortunately, okay. Your network is breaking.
Dr. Kalejaiye,
Yes.
Dr. Mabogunje, please, there's this question on my mind. And that question is, Nigeria
Please,
has
is
the
there
highest sickle cell
any other
burden.
alternative?
Okay, Elmo, hold on. You're breaking up. So there's a question here before
Before I come,
just Yomi continues. There's a question here that's it says talking about priapism. I was on a hydroxia some time ago. Then I noticed I started having priapism frequently. So I had to discontinue it. What could have gone wrong?
Okay, let me try to answer to that. Now, hydroxyurea is not the only drug that we prescribe for priapism. Yes, in addition to hydroxyurea, we do prescribe some other medications that can help alleviate priapism as best as possible. I guess the question is now, apart from priapism, what other medications were you given?
Mm. You mean apart from
And
hydroxyurea?
Yes, we
yes.
add on
And
other
how was he
medications,
using it?
yes.
Yes.
And then
And
what
how
Yeah,
dose
was
were
he?
you
so,
And how was
given?
he using it?
Exactly.
Yes. Yeah. So I
okay,
think
now
the
what
best
yeah.
thing is to go back and see their doctor so that they can
Yeah,
discuss it through and be sure that they need to be off the hydroxyurea, not just take himself off the
to start with,
hydroxyurea.
yes. Let's
Yeah, I
look at
think
the
a lot of people
dose.
feel that they have to take it off and they just abruptly, and but there's a
Yeah.
process. You even have to review on a regular basis
Yes,
with a
exactly.
higher dose or not.
agreed.
Yeah.
Yeah, before you just remove yourself from it.
Mm,
Yeah. Mm.
mm.
Okay, there's another question here. Uh, um, is it possible for my liver to be overworked after 2 weeks of a cesarean section? Because I bleed profusely and was told it's cause of an overworked liver. Can you please help me explain this? Yeah. So the person
Now
is
the
with sickle
liver.
cell, like had a C-section.
Now, I do not know if this person had a sickle cell hepatopathy or the liver being affected prior to this cesarean section, or were there other things like maybe septicemia, you know, that could affect the liver enzymes and cause eventually reduction in platelet count and will cause the patient to bleed. I think the history around the delivery and the cesarean section has to be properly looked into, because certainly it's
Mm,
not all patients that go through cesarean sections are just poor. So I think
yeah.
a little more about that history needs to be known, and I don't think it's quite clear. Yeah,
Okay,
as we speak.
I think you need to go back for a review. Maybe go to somebody who may has a better
Yeah,
understanding of the situation. I know you're far away from Luth because I know you, but maybe that's something you should look at and see if they can review the situation. You know, yeah. All right. I don't think there's any more questions. So Yomi, I'll leave you with your last question, and then
Okay, so
we close.
let me quickly ask this question, man. So the question is, sickle cell does not only affect us in Lagos. There are some far-flung places where
Mm.
probably they don't even have one hematologist. How are you helping us to get this education to probably those places, probably primary health centers, people working there, doctors working in primary health centers? Are there some things you are doing, maybe as an association or maybe as a group or probably individually, that you can help us in that regard?
Um, okay, Dr. Kalejaiye, I don't know, the Hematologist Association, are they doing anything? I know that I understand what you're saying, Yomi, and I think it is a real issue, you know. But that takes government policies and all. I don't think any one individual will go to all the rural areas and start teaching. Obviously, if you have the opportunity to, you will. But I think the government needs to come up with policies that will ensure that there are hospitals in strategic places all over where people can have access to care and thus education and all those other things. But I don't know whether there's anything the Hematology Society of Nigeria is doing with regards to that.
Well, I know we're still working on a lot of its all about advocacy, advocacy, advocacy. You
Mm.
know, and definitely we definitely need a lot of government input to be able to achieve
Mm.
that as best as
Mm.
possible.
Mm.
But we do encourage referrals as best as we can. You find something that you're not entirely familiar with, that person, without a medical officer who's there, should at least know the limits to, they must know how far they can actually treat and know
Yeah.
when to refer to tertiary centers, or those secondary or tertiary centers. And that could go a long way
This is
in
raising eyebrows.
alleviating our burden for now.
Dr.
But can we go
Kalejaiye,
to every rural
that is
center
in
and
the
stop?
utopian world. Most people want to treat people they don't know.
Oh dear.
Even in your private hospitals, they know they cannot handle the situation because of they will still, you see, they will take the situation and not refer.
In fact, that's another matter entirely. But I know for the government, for the primary health centers under the local governments and things, and they have
Yeah.
access to
Yeah.
general hospitals, and they also have access to the other teaching hospitals. So that may not be as much as a problem as those that private people that just choose to cling to their patients in the kingdom come. That's another matter entirely.
Mm. Wow, we definitely have a lot on our hands, and we hope that even wherever this is talked about, people can take it up and push for more issues to deal with these challenges that we face. I want to thank everybody. We could go on and on
Mm-hmm.
because this
Yeah.
issue is not exhaustive at all. But thank you so much for spending time with us and sharing with us. And one takeaway from this is that each and every one of us must be informed, regardless of
Yeah.
whether you're seeing a doctor or not. Be informed. It is your body. I always tell people, ask why the doctor gave you this drug. It's your right.
Mm-hmm.
Mm.
You're
Mm-hmm.
right.
Mm-hmm.
Don't be afraid. Don't think that oh, it's a doctor, he's God. You cannot ask. No, it's your right. And you can ask, you can inquire, and then you can even improve your education even better by communicating with people who are in the know about your health. Don't be afraid to ask. Once again, thank you so much. From
Yeah.
Yomi and I and Advocacy and Management Initiative. This has been an interesting talk and interesting experience. I hope to have both of you again because I know this thing is it's a lot.
Would love to come back.
Yeah, please.
Yes,
Thank you for having
anytime.
me.
Yeah.
Uh,
Thank you
so
for having us.
thank
God
you so
bless.
much.
Okay.
So have a great weekend, everybody. Sunday is
Okay.
tomorrow.
Doctor,
Tomorrow is the last day of your holiday. And work begins on Monday, but enjoy your weekend and God
We'll
bless.
try. Okay. God
God
bless.
bless. Bye.
Bye.
Bye.